Hello. So good afternoon. I hope a lot of you are joining. I can see the numbers are rising. Thank you very much for registering to this EFSA webinar on the activities on tolerable upper intake levels for vitamins and essential minerals. We're very happy to be here and being able to talk about our job. This is very much in line with EFSA's policy of engagement on our scientific activities. And I will just do a brief introduction, explain the housekeeping rules, let's say, and I will pass the floor then later. So in terms of housekeeping rules, just you are automatically connected to the audio broadcast, but it's a one-way audio. So you will be on listen-only mode. This event is in English and it will be recorded, and the recording will be published on EFSA's website for future use. After the event, the attendees will receive a link to a survey to evaluate this webinar. We do this for all our events and it allows us to improve. So please answer to our survey. Next. So we're really happy with the registrations we've received for this event. I think we have an absolute record of 1,564 registrations from 72 different countries. So we're extremely proud of the interest this event has created, and we hope that you will find it quite good in addressing the questions that you may have about EFSA's work. Now, we did receive some questions, more precisely 33 questions in preparation for this webinar. Those that are directly linked to the content of the presentation will be addressed by the speakers as they provide their various sections. There will also be a space at the end of the webinar where we'll address the remaining questions. So I hope we'll manage. For today, first of all, the chair of this event, Dr. Androniski Naska, that is a professor of hygiene and epidemiology at the School of Medicine of the National and Kapodistrian University of Athens in Greece. Ada is also the chair of the EFSA working group on upper levels and a vice chair of the EFSA NDA panel. Then we will have several of our staff here at the NIF unit in EFSA, and that's Agnes, Senior Scientific Officer, Jonet, also scientific officer in the unit, Nena, Leonard, and Lucia Fabiani. So I think without further ado, we can indeed just give you an overview of what we are trying to achieve today. And it's quite an extensive agenda for the time we have, which of course needed to be so because this has been a very comprehensive work, not just in answering to specific mandates we received regarding fat-soluble vitamins, vitamin B6, folate, essential minerals, but also on the methodologies that were developed to address these mandates. So we will start with presenting the general framework and also provide a specific session regarding how intakes of vitamins and minerals were estimated for the purpose of these mandates. I think this was it. So Ada, the floor is yours now.
Thank you, Anna. And good afternoon to all attendees, and a warm welcome also from my part to this webinar, which aims to provide insights on the principles and methods applied for the evaluation of ULs. Let's use this short term for the main protagonist of the day, the ULs for micronutrient, and also to summarize the conclusions reached on each of the micronutrients recently evaluated. In the presentations that will follow, I strongly invite you to conceptualize the upper level as the maximum amount of a nutrient that can be consumed safely over a long period of time. These are values which are based on evidence, on scientific evidence. They are established by EFSA, and their establishment, their setting, forms part of the risk assessment process. When the risk assessment process is complete, these values can be considered in risk management. And risk management relates to the maximum amount, to the MA, the maximum permitted amount of a nutrient that can be added to foods or used in food supplements. And these values are legal values which are established by regulators. This is a very important slide because in our presentations today, it is important to keep in mind that the UL and the MA are two distinct values. One is the outcome of the risk assessment, that is the upper level, whereas the maximum amounts are the outcome of risk management procedures. A few things about history. In 2000, the Scientific Committee on Food adopted guidelines for the development of ULs for vitamins and minerals. 2 years later, EFSA was born, and EFSA's NDA panel took over the work of the Scientific Committee, and until 2005, the ULs for vitamins and minerals were published. In the years that followed, some ULs have been updated following specific requests, specific mandates, such as the UL for calcium and vitamin D in 2012, and the UL for vitamin D in infants in 2018. And we come today to the last 4 years, from 2020 up to 2024, where the European Commission sent a mandate to the NDA panel to update firstly the guidance on setting the upper levels, and then to update the upper levels for the vitamins and minerals that you see in the screen. So in my last slide of my introductory remarks, I will give you in a nutshell what you're about to follow. The European Commission shall set maximum amounts of vitamins and minerals to be added to foods and used in food supplements. This is part of the risk management process. To do this, the European Commission requested EFSA to update the methodological guidelines of the Scientific Committee of Food published in 2000, based on these guidelines to review the evidence and provide advice on the upper levels of the vitamins and the minerals that you see on the screen. And in addition to that, when no UL could be set, to provide advice on the highest level of intake, which could be considered with reasonable confidence as not to raise safety concerns. The presentations that will follow will address folic acid and folate, vitamin B6, vitamin A, including beta-carotene, vitamin D, E, and the minerals iron, manganese, and selenium. And with this, I will give the floor to Agnès de Sesmaison to help you become familiar with the UL assessment framework.
Thank you very much, Ada, and good afternoon to everyone. I'm very happy to have the opportunity this afternoon to present the framework that has been developed at EFSA to evaluate ULs. And I would like to start by giving you a quick overview of the main steps that we followed for that project and of the timeline. As mentioned by Ada, we were requested to reevaluate the tolerable intake levels for 9 nutrients. We started the work back in 2021 and finalized it this year. And so over these 4 years, we were very busy collecting the necessary data, evaluating it, and we're starting to publish the different opinions in 2023 and finalize the publication in 2024. So in total, we have published 8 opinions and 1 guidance document, which you can find in the EFTA journal. As you can imagine, this represents a big amount of work that we had to produce in a short time frame. And so we collaborated with a consortium of universities in Nordic countries, which conducted part of the preparatory work which was needed for these assessments, especially the systematic reviews that represented the core of the data collection. We also ran a public consultation for each of the opinion, and we were very pleased to receive numerous comments on the opinions, many of which help us improving the clarity of the opinions. So the focus of my talk will be on the guidance document. As mentioned by Ada, we were requested by the European Commission to update some methodological guidelines which had been previously established by the SCF back in 2000. A draft of the guidance was published at the beginning of 2022 after an expert workshop that was organized at the end of 2022, where we collected input from experts on the areas of the previous guidelines which required revisions or further elaboration. The guidance was then finalized this year based on the experience we have gained with the evaluation of the different nutrients, and it was published actually last week, so very fresh. My talk is going to present the key elements of the guidance, but of course I invite you to consult the document for further information or details. I will start with the definition of the UL. And the UL is one of the reference value among the so-called dietary reference values, which are established by EFSA to guide professionals on the amount of nutrients which is needed to maintain health on the one hand, so the physiological requirements as illustrated on the left-hand side of the figure, and to prevent for adverse effects related to excess intake of the nutrient on the other end, so the so-called UL. A UL is defined as the maximum level of total chronic daily intake of a nutrient from all sources, which is not expected to pose a risk of adverse health effect to humans. And there are several concepts embedded in that definition that I would like to highlight. The first one being that the ULs is normally established for the nutrient from all dietary sources. However, there are some exceptions, and in some cases, the UL may be restricted to specific sources or specific forms of the nutrient, and we will hear about some cases later on this afternoon. Also, we should keep in mind that these values do not consider adverse effects related to acute bolus dosages, and also that this value refers to average daily intake. So what matters here is the chronic consumption of the nutrient by consumers, having in mind that there are obvious day-to-day variation within an individual intake of macronutrients, but what matters is the average intake. In terms of the risk assessment process, you will recognize the steps which are classically applied for the risk assessment of chemicals in food, as identification and other characterization steps, intake assessment, and finally, risk characterization. So actually, this framework was already adopted back in 2000 by the SCF and has not changed. Because it has proven to be operational and very useful for the evaluation of nutrients. However, there are specific considerations which are required when it comes to nutrients as compared to other types of chemicals. In particular, the fact that there are specific mechanisms that maintain homeostasis and regulate the accumulation of the nutrients over a range of intake, at least for many of the nutrients. And also, we need to take into consideration the fact that they have a physiological role. So there is a nutritional requirement for those compounds. And this needs to be considered because we cannot set up a level which are below the levels which are considered to be necessary for fulfilling the physiological requirements. In terms of framing the risk assessment, our process starts by the formulation of risk assessment questions, and this relies on three pillars: the definition of the exposure of interests, the identification of the relevant endpoints or health effects, and the definition of the target population. And I'm going to give you a little bit more details about the consideration we made in the coming slides. So, starting with the determination of the exposure of interest, as I said, the UL relates to the total chronic daily intake of the nutrient from all dietary sources. And so it covers the chemical forms which are naturally present in food and also those which are authorized for addition to food or for use in food supplements. All of these different chemical forms are considered in the assessment. And of course, we need to keep in mind that different chemical forms may exhibit different properties with regard to their absorption, for instance, their distribution, metabolism, excretion, also their function, and that this may also be influenced by the food matrix or the vehicle through which they are consumed, or also the consumption patterns. And this difference in bioavailability between different sources or different chemical forms may influence the nature and the severity of the adverse effects related to their intake. And of course, this is an important element for consideration in our assessment. In preparation of this meeting, we received actually a question from stakeholders on whether we consider, for instance, differences between organic or inorganic forms of minerals. And indeed, keeping with this principle, this is very much the case, provided that there is, of course, sufficient scientific evidence to characterize these differences. And an example of such consideration can be found, in our opinion, on selenium, for instance, but we will come back to that later today. In relation to the selection of endpoints that we are assessing in our evaluation, these figures illustrate the generic chain of potential events which accompany increasing intake and body content of nutrients. So the arrow at the top progress from adequate to excessive intake, and what you see in the different text boxes describe the potential physiological and pathological responses to increasing intakes. These responses can involve, for instance, reduced absorption of the nutrient, increased excretion, and as we go down the figure, increased deposition of the nutrient in tissues, and ultimately potential functional and architectural damage. Early events are likely to be reversible. However, if high intake is maintained, irreversible tissue and organ damage may occur. Interestingly and important to highlight is that the classical toxicological approach has relied on the identification of signs and symptoms of overt toxicity and disease, so focusing on the bottom part of the figure. However, over the past decades, experts committees have moved towards exploring more biological-based approaches. And the aim of these approaches is to identify earlier marker of excess intake, which can be validated as predictor of potential toxicity. And these markers are identified among the events which are described in the upper part of the figure. The evidence for the identification of these endpoints typically comes from human studies, so human data, experimental or observational, but animal data can also be useful to identify target organs or pathologies, as well as intermediate steps in the chain of events that I have described. So finally, closing with the third pillar and the identification of relevant population. By definition, the upper level should be protective for all members of the general population throughout their lifetime, from infancy to older age. Of course, specific consideration might be required for particular life stages, like, for instance, during pregnancy or infancy, where groups might be more susceptible or more vulnerable to adverse effect of nutrients. So we are reviewing whether there is any indication in that direction. And on the other hand, a UL may exclude specific subgroup population. And those are those which are identified to have distinct vulnerabilities due, for instance, to genetic predisposition or other factors such as specific medical condition, use of certain medication. So if such groups are identified during the risk assessment process, it might be decided to exclude them from the coverage of the upper level, and we will come back to that with some example later on. I'm now going to present briefly the approach we apply to collect the evidence needed for our evaluation. So this slide illustrates the data collection and evaluation process, which is used to inform the hazard identification and hazard characterization step of the assessment. Typically, EFSA conducts systematic reviews to address the questions on the relationship between nutrient intake and adverse effects or surrogate endpoints. But these systematic reviews are focusing on priority endpoints, because this is a very time and resource consuming process. So we go through a prioritization step in which we identify the endpoints which are most likely to inform the establishment of an upper level, and the other endpoints are covered by narrative reviews. I'm not going to enter into details into the different steps of the systematic reviews, because we follow what is well accepted in the field in terms of the process and methods. Importantly, ultimately, there are different ways we might be synthesizing the data depending on how much data we found and the potential heterogeneity across the data. So we might go for a more narrative synthesis when data are limited or very heterogeneous. But in some instances where we have a good body of evidence and comparable studies, we might also conduct a meta-analysis. I also wanted to mention the uncertainty analysis framework that we apply, especially to derive or draw our conclusion with respect to hazard identification. So this framework is adapted from the framework of the US National Toxicology Program. And it shares some similarities with the GRADE framework for those who are more familiar with GRADE. And it actually integrates different elements to draw an overall conclusion about the causality of the relationship which is investigated. So these elements include identified bias or risk of bias in the evidence, the heterogeneity or imprecision of the data, any evidence for publication bias. We also make consideration about the external validity of the data and the consistency of the data across different endpoints. So the result of this analysis, the experts involved in the assessment express their certainty in the causality of the relationship using a 4-level scale: very low, a low, moderate, or high certainty in the causality. So once we have concluded on the different hazard and identified the most relevant hazard for the nutrient of interest, we need to select the endpoints which are the most biologically relevant for the assessment and derive a reference point from that endpoint. There are, in many instances, several adverse effects which are identified in relation to one nutrient, and so we need to select a critical effect, which is typically the effect occurring at the lowest dose. The rationale for this selection is provided in each of the evaluation. And then we move to the characterization step, where we need to characterize the intake-response relationship between the nutrient of interest and the endpoint selected. Whenever possible, we apply intake-response modeling. However, we do not always have the necessary data to apply this type of statistical approach, in which case we revert to more traditional approaches like identifying a no observed adverse effect level or lowest observed adverse effect level from the data set. But what I want to stress here, and important to highlight, is that the determination of a UL implies that we have experimental or observational data which are of sufficient quality, and also which cover a range of intakes which actually include the levels eliciting the adverse effect. And actually, this is not always the case. And we will hear some examples this afternoon in relation to iron and manganese, where although adverse effects are well characterized, we were not in a position to derive an upper level. Following the identification of the reference point, we apply uncertainty factor to cover for the variability and sensitivity among individuals and for any uncertainty in the data. So basically, the concept is that the greater the uncertainty, the larger the uncertainty factor we applied, and the lower the resulting upper level. And the choice of the uncertainty factor is really made on a case-by-case basis, based on expert consideration, which take into consideration the totality of the evidence available on the effect under consideration, as well as the essential role of the nutrient, so the physiological requirement and any knowledge we might have about homeostatic mechanism applying to the nutrient. In relation to scaling, very often data for age group other than adults are scarce, unfortunately, and we need to establish UL for younger age group by extrapolating from the UL for adults, which are typically those for which we have most data. So there are different methods to do that. The most common are isometric or allometric scaling. Very quickly, the assumption behind these approaches is that the same set of physiological or metabolic responses to nutrient operates across all age groups, and that the main difference, quantitative difference between the different age groups is mostly a matter of scale, so actually a function of body size. And so specifically, when we apply allometric scaling, it allows us to account for the higher metabolic rate of children compared to adults. As I mentioned, we do not have always the necessary data to conclude on an upper level. And in that context, the Commission asked us to still provide an indication of the highest level of intake for which there is reasonable confidence on the absence of adverse effect. And we have called that safe level of intake. The concept is illustrated on the right-hand side of this slide. And basically different from a upper level, a safe level of intake is based on data which characterize levels of intake up to which no observed effects, no adverse effects have been observed. So the data used to establish such value are quite different from the data we would use to set an upper level. And you will hear some example later this afternoon in relation to iron and manganese. And so what you need to keep in mind when facing a safe level of intake is that it indicates that more research is needed to determine with some degree of certainty where the actual threshold for adverse effects lie, and thereby to establish an upper level. So because of this greater level of uncertainty in the evidence, a safe level of intake has more limited application than a UL and needs to be interpreted with extra caution. And I'm ending this presentation by briefly presenting the main principle of the risk characterization. As illustrated on this slide, it typically involves comparing estimated intakes in European population with the established upper level or safe level of intake. And if the estimated intake are below this health-based guidance value, basically we are quite confident that there is no risk, or at least no risk is identified in the population, while when this intake estimates exceed these values, this is raising a red flag. However, some refinement might be needed in characterizing the risk, and it needs to take into account the accuracy of the intake estimates, also the magnitude and duration of any exceedance, and the nature and severity of the adverse effect before one can really conclude on the risk. And in this last part of the opinions, we also discuss any evidence we might have found on specific subpopulation or groups which have distinct sensitivity to the adverse effect and that we decided to exclude from the derivation of an upper level. And again, you will hear some examples of that, for instance, in relation to vitamin E. And with that, I'm finishing my presentation. It was a lot of information, so I hope it was not too overwhelming, especially for those who are not so familiar with the framework, but I would warmly invite you to refer to the guidance for more information. And I'm happy to give the floor to my colleague, Yonut Krashun, who will guide you through the conclusion we reach on fat-soluble vitamin. Thank you.
Thank you, Agnes, and good afternoon, everyone. For the next 30 minutes, I'll be going through the highlights from the recent UL opinions on fat-soluble vitamins, specifically on vitamin A, D, and E. So starting with vitamin A, I'll begin by discussing the previous assessment that served as the foundation for our current evaluation, which our recent assessment updates and supersedes. For beta-carotene, the Scientific Committee on Food, which is the body that was responsible for EU risk assessments in the area of nutrition before EFSA was established, they had concluded that there was insufficient scientific basis to derive a UL due to the lack of a dose-response relationship. And this was based on evidence from human intervention trials that report on lung cancer. And they then stated that supplemental beta-carotene at the intake of 20 milligrams per day or more is contraindicated for use in current heavy smokers. In 2012, then, the EFSA ANS panel had also assessed the safety of beta-carotene for use as a food additive and in food supplements. And based on human data, they concluded that the exposure to beta-carotene from these sources at levels below 15 milligrams per day is not associated with adverse health effects in a general population, including heavy smokers. In 2002, then, the Scientific Committee for Food also conducted a risk assessment for preformed vitamin A, where they derived the UL of 3,000 micrograms of retinol equivalents per day for women of childbearing age. This was based on the critical effect teratogenicity, and they considered this UL also appropriate for other population groups, as it was 2.5 times lower than the lowest daily intake that was associated with hepatotoxicity during a chronic intake. The SCF also advised that intakes of preformed vitamin A should be restricted to 1,500 micrograms per day in postmenopausal women. This is due to its effects on bone mineral density and bone fracture risk. Before moving on to hazard identification, I just want to emphasize an important point, and that is while developing the protocol and when conducting scoping searches in preparation for the update of the UL for beta-carotene, we observed that there was no new supplementation trials with high doses of beta-carotene, so that is above the 15 and 20 milligrams per day that had been conducted since the previous assessments by the SCF and the EFSA ANS panel. And this is largely due to the ATBC study results on lung cancer risk. Additionally, the evidence that was available for other adverse effects was limited and conflicting. So therefore, in the context of deriving the UL, the panel decided at the protocol development stage that the focus on supplemental beta-carotene should be assessed the source of vitamin A and focus on its potential to increase preformed vitamin A toxicity. The priority adverse health effects, which were expected to play a critical role in developing or establishing a UL, were addressed through systematic reviews. These are teratogenicity, hepatotoxicity, and bone health, and these outcomes were identified after consultation with a panel of experts on vitamin A and with discussion with the working group on ULs. Other adverse effects that are associated with excess beta-carotene or preformed vitamin A intake are addressed through narrative reviews of the literature, and these are not considered priorities for setting a UL based on discussions with experts again, and the limited and conflicting evidence or that they were observed at doses that are much higher than the current UL. And I'll now move to the conclusions of these priority adverse health effects. And regarding teratogenicity, the teratogenic effects of preformed vitamin A at high intakes have been well established and documented in the literature, both in animals and humans. And the aim of this systematic review in our assessment was then to characterize the dose-response relationship between high intakes of vitamin A and teratogenicity. Since the previous assessment by the SEF, 2 new prospective observational studies and several case control studies were identified, though the majority of these were at index level below the current UL. Only one prospective cohort addressed the dose-response relationship between the intake of preformed vitamin A and birth defects and identified a threshold of 3,000 micrograms of retinal equivalents per day for supplemental retinal and cranial neurocrest defects. And this was supported by findings of another prospective cohort and several case controls that have assessed intakes of preformed vitamin A below and above this threshold. The panel then noted that beta-carotene per se is not considered to be teratogenic. This is due to downregulation of beta-carotene absorption and conversion to retinol in vitamin A repleted states. It's also unlikely that maternal beta-carotene intakes from food or supplements would potentiate the teratogenic effects of preformed vitamin A, although the data did not allow us to address this question. Regarding hepatotoxicity, the relationship with high intakes of preformed vitamin A is also well established. So the aim here was to characterize the dose-response relationship, with hepatotoxicity being a late symptom of hypervitaminosis A, and also one of the most severe outcomes. Liver abnormalities associated with chronic intakes of preformed vitamin A range from elevated liver enzymes that are reversible to also widespread fibrosis, cirrhosis, and sometimes even death. So the systematic review that was restricted to randomized controlled trials only, of the ones identified, none of them used histological endpoints to assess hepatotoxicity and reported only on liver enzyme and observed no adverse effect. None of these RCTs tested doses below the low L for liver damage that was previously identified by the SEF in their assessment. And the available evidence also did not allow to explore whether high intakes of beta-carotene could potentiate preformed vitamin A-induced hepatotoxicity. Therefore, the available evidence does not allow to characterize the dose-response relationship. Then for bone health, as I mentioned earlier, the SEF had advised postmenopausal women to restrict their intake to 1,500 micrograms per day due to the observed association with increased risk of hip fractures in 2 observational studies. However, they also expressed uncertainty regarding the causality of this relationship and found this endpoint or the data on this endpoint insufficient to set the UL. The aim of the systematic review in our assessment was to investigate whether the intake of preformed vitamin A alone or with beta-carotene could adversely affect bone mineral density and the risk of bone fractures in older adults and postmenopausal women at daily doses up to the UL, so up to 3,000 micrograms per day. The eligible studies included human intervention studies and prospective observational studies, though we didn't identify any RCTs. The evidence that we did identify from prospective cohorts at levels below the current UL, so below 3,000, was conflicting, and the evidence available since that assessment in 2002 does not support the association between preformed vitamin A and impaired bone health. So considering the genetic, environmental, and age-related factors that affect bone metabolism and fracture risk, along with the uncertainties and divergent evidence in the studies identified, the panel concluded that the causality of the relationship between preformed vitamin A at intake levels below 3,000 and increased bone fracture risk cannot be established. So there's also no evidence that dietary beta-carotene could contribute to preformed vitamin A toxicity on bone. So for the derivation of the UL, the panel selected teratogenicity as the critical effect to base the UL. This endpoint, while being only relevant to women of childbearing age, it represents an irreversible form of toxicity that occurs at relatively low intakes. A UL based on this effect would also cover for other adverse effects of excess preformed vitamin A, and the lowest doses reported to cause other adverse effects were quite a bit higher than this threshold for teratogenicity, And for bone health, as I said, the causality of the relationship could not be established below this threshold. Since beta-carotene is not considered to be teratogenic and maternal supplemental beta-carotene is unlikely to potentiate teratogenic effects of preformed vitamin A, the UL should only apply to preformed vitamin A. So the panel decided to retain the UL previously set of 3,000 micrograms per day, and this applies to all adults. It was based on a prospective cohort, and no uncertainty factor was deemed necessary because the true threshold indicated by other data seems to be much higher than this. The US or the upper level applies to all adult populations, but also postmenopausal women, which differs from the SEF's recommendation due to the new evidence I presented on bone health that further questions this causality of the relationship. The panel also proposed to retain the UL for children and adolescents, which is extrapolated from the UL for adults based on allometric scaling and to account for the differences in basal metabolic rate. So here you can see the values established. It said no change compared to the Scientific Committee on Foods assessment, though we did also establish values for infants, which was not the case in the previous assessment. We used allometric scaling based on the adult UL, and the UL for infants aged 4 to 6 months and 7 to 11 months, rounded down to the nearest 100, would have been 500 and 600 micrograms per day, respectively. But considering the secretion of retinol in breast milk, particularly during the first 6 months of lactation, the panel considered this would be over-conservative for the youngest infants, so decided to apply the 600 micrograms per day to all infants, so between the ages of 4 to 11 months. And then finally, regarding beta-carotene, the panel selected lung cancer risk as the critical effect of excess supplemental beta-carotene. An increased risk of lung cancer was observed in 3 out of the 4 RCTs that we identified, at least from the ones that conclusions could be drawn. And this was only statistically significant in the ATPC trial, which was conducted in heavy smokers and supplemented with 20 milligrams per day for 6 years. There were, however, several sources of heterogeneity for the effect of supplemental beta-carotene on lung cancer risk that could not be characterized. So therefore, it's unclear whether the differences in risk across the studies identified depend on the sex, baseline risk, supplemental dose, type of supplement, or its bioavailability, pattern administration, and other factors, or any combination of these. There's also no data available on supplemental beta-carotene given alone at doses below 20 milligrams per day in any population group. So therefore, the panel considered that the available data from RCTs was not sufficient and suitable to characterize a dose-response relationship or to identify a reference point for supplemental beta-carotene. And in the absence of adequate data, no UL could be established. There was, however, no indication that beta-carotene intake from the background diet or from its use as a food additive, so for technological purposes, such as a food colorant, there's no indication that it's associated with adverse health effects. Without the upper level, the risk associated with the consumption of supplemental beta-carotene cannot be characterized, so the panel recommended that smokers avoid consuming food supplements containing beta-carotene. And because we received a question on this, how this recommendation will be implemented and communicated to consumers falls within the remit of risk managers. And lastly, the panel also considered that the use of supplemental beta-carotene, so in food supplements and food fortification or fortified foods, by the general population should be limited to the purpose of meeting vitamin A requirements as defined by population reference intakes previously established by EFSA. So moving on to vitamin D now. For this revision of the UL, we started also with a previous assessment, this time conducted by EFSA in 2012. UL for adults of 100 micrograms per day was established, which was based on an OL for hypercalcemia of 250 micrograms per day. To this, an uncertainty factor was applied of 2.5 to account for the low number and short duration of the studies, the limited sample size, and the characteristics of the subjects, which was young males only. I should also mention that in this scientific opinion, we actually also addressed another mandate, or in this revision of the EL, we addressed another mandate to assess the relative bioavailability of calcium monohydrate as compared to vitamin D3, and to provide a conversion factor. I will not enter into details how this conversion factor was derived because of the context of this webinar, but just to inform you that conversion factor of 2.5 was established. So the priority adverse health effects as for vitamin A were identified in consultation with panel of qualified experts on vitamin D, and after discussion with the working group on upper levels. The outcome expected to play a critical role for establishing UL were persistent hypercalcemia and hypercalciuria, as well as musculoskeletal health, and these were addressed through systematic reviews of the literature. Other adverse health effects were then addressed through narrative reviews of the literature. For the relationship between the intakes of vitamin D and the development of persistent hypercalcemia and hypercalciuria is well established. Hence, again, the purpose of the systematic reviews focused on the characterization of the dose-response relationship. And eligible studies were only human intervention studies. Cases of persistent hypercalcemia and hypercalciuria were defined as those with elevated levels or calcium concentrations in the blood or urine respectively, as defined within each study and confirmed through repeated testing. Then onto conclusions based on the evidence from RCTs in adults, the panel concluded that vitamin D supplementation alone at doses up to 250 micrograms per day for 5 to 6 months does not increase the risk of hypercalcemia. Persistent hypercalciuria was not assessed under these conditions. Vitamin D supplementation then at doses of 250 micrograms per day for a period of 1 to 3 years in co-supplementation with calcium to reach adequate levels in the study population increased the risk of persistent hypercalciuria by about 3 times as compared to doses of vitamin D that fall within the range of adequate intake, even when calcium supplementation was either reduced or withdrawn. Cases of persistent hypercalcemia or hypercalciuria did not occur or could not be attributed specifically to the dose of vitamin D when the vitamin D supplements were given alone up to a dose of 100 micrograms per day, or up to 125 micrograms a day when they were given in combination with calcium, or when it was a shorter duration study, so between 3 and 6 months. Due to the limited number of the RCTs that reported cases of hypercalciuria per intervention arm and the lack of RCTs that were available between the doses of 125 to 250 micrograms per day, no quantitative evidence synthesis via dose-response relationship was performed. Then for musculoskeletal health, the endpoints of interest included the risk of falling and risk of bone fractures, with eligibility being limited only to human intervention studies in older adults and post-menopausal women. We also reviewed evidence from human intervention studies and prospective cohorts that reported on BMD, or bone mineral density, bone mineral content, and indices of bone strength. Based on the available evidence that we identified, the panel then concluded that RCTs with vitamin D doses up to 250 micrograms per day, consumed for 1 and up to 5 years, do not suggest an increased risk of falls or fractures versus control or lower doses or a placebo. RCTs do not suggest an adverse effect of high vitamin D intakes up to 50 micrograms per day in children and up to 250 micrograms per day in adults, periods over 1 year of supplementation, and then on aerial BMD at several bone sites, and this was assessed with DEXA scans. We did identify one RCT that tested doses up to 250 micrograms per day for 3 years, which is the longest period of the studies that we identified. And this reported a negative dose-response relationship between vitamin D supplementation and volumetric BMD at the radius in tibia, though this did not translate into differences in measure of bone strength, which was failure load that was assessed in this study. So although the potential adverse effects that of high vitamin D supplementation or markers of bone health should be further explored, along with the ability of such markers to predict fracture risk. Volumetric BMD alone cannot be used as a critical endpoint to base the UL on. Whereas, as I said, the hypercalcemic and hypercalciuric syndrome is well established. Adverse effects of vitamin D toxicity on musculoskeletal health have only been reported in the one RCT. So based on the favorable evidence, the panel decided then to select persistent hypercalcemia and hypercalciuria as the critical effect on which to base the UL for vitamin D. We identified the lowest observed adverse effect level of 250 micrograms per day. This is for persistent hypercalciuria, and this is based on evidence coming from 2 RCTs. The uncertainties considered by the NDA panel in the previous assessment in 2012, and where they applied an uncertainty factor of 2.5 to derive the UL from an OL at the time, have been addressed by the new evidence that we identified, and this because this includes both males and females with adequate vitamin D status, older age, larger sample size, and also longer duration. However, the panel also considered that an uncertainty factor of 2.5 would still be appropriate in this case to account for low L being used as the reference point. An upper level of 100 micrograms of vitamin D equivalents was derived for adults. This includes also pregnant and lactating women, as well as adolescents aged between 11 and 17, as there's no reason to believe that they would have a lower tolerance for vitamin D than adults. This is also supported by a large body of evidence where we had doses between 100 to 125 micrograms per day with or without calcium, and given to several populations for longer periods, more than 1 year, where there was no persistent hypercalcemia or hypercalciuria observed. At least that could be attributed to the vitamin D dose. And also cases that we did identify were rare and occurred only in calcium co-supplementation that generally resolved after calcium withdrawal. So the UL covers dietary intakes of vitamin D from all sources, applies to all forms of vitamin D authorized for addition to foods and food supplements. So this is vitamin D3, D2, but also the recently authorized form, calcium monohydrate. And this is why we introduced the term vitamin D equivalent, because of calcium monohydrate, and to express the biological value of substances with vitamin D activity. So this applies to calcium monohydrate at doses up to 10 micrograms per day, for which safety was established in the context of a novel food application. And finally, the UL for children aged 1 to 10 was derived based on their lower body weight. So as I said here, you see no difference from the previous assessment in the final value. And as I mentioned at the beginning, that the value for infants was not reassessed in this assessment because of a recent assessment in 2018. Then moving on to vitamin E, the Scientific Committee on Food then evaluated the UL and established a value of 300 milligrams per day, which applied to all tococriminals. This was based on the effect of vitamin E on blood clotting with an OL of 540 milligrams per day for all RAC alpha tocopherol, which is identified from a randomized control trial. To this, an uncertainty factor of 2 was applied to cover for the inter-individual differences in sensitivity. In EFSA's DRV opinion in 2015, the panel had concluded that alpha tocopherol was the only physiological active vitamer aligning with other authoritative bodies. So in the revision of the UL, vitamin E now refers only to alpha tocopherol. For the priority adverse health effects, which are expected to play a critical role for establishing UL, these are identified based on previous risk assessments for alpha tocopherol, and these were addressed, as was the case for the other nutrients, through systematic review of the literature. And these include impaired blood coagulation and risk of bleeding, cardiovascular disease risk and mortality, and prostate cancer risk and prostate cancer mortality, with the other adverse health effects that you see here, which being associated with excess alpha tocopherol, but not being considered priorities for the purpose of setting a UL. And these were addressed through narrative reviews of the literature. So moving on to impaired blood coagulation and risk of bleeding, this is also a well-established relationship, at least in animals, where high doses of alpha tocopherol increases the risk of bleeding. And it is believed that similar mechanisms also could potentially affect humans. The current systematic review in this assessment was to evaluate whether new evidence from human intervention studies allowed the characterization of a dose-response relationship between alpha tocopherol intake and impaired blood coagulation. However, of the human intervention studies that we did identify, there was no relevant data on the risk of bleeding events with alpha tocopherol supplementation. The studies that we did identify did not show an effect on prothrombin time and activated partial thromboblastin time. And this is with doses up to 800 milligrams per day for up to 12 weeks. Then the effects on platelet function, such as reduced platelet adhesion and ATP secretion, were observed but did not translate into changes in bleeding time. And this is with doses up to 728 milligrams for up to 4 months. And these are all in studies conducted in populations not taking anticoagulant or antiplatelet drugs. For cardiovascular disease risk and mortality, the panel then concluded that the available evidence, this is from RCTs and from prospective cohorts, does not suggest a positive relationship between alpha tocopherol intake and increased risk of several endpoints here. So cardiovascular disease is a composite endpoint, myocardial infarction, angina, coronary heart disease, total stroke, or ischemic stroke. There was, however, some evidence for increased risk of hemorrhagic stroke and congestive heart failure with alpha tocopherol supplementation, but this is in specific populations only. These were participants in the secondary prevention trials for cardiovascular disease or treatment, those with treatment with antiplatelet medication. So such individuals are under medical care, and any alpha tocopherol supplementation should be under medical supervision. So these individuals are excluded from the target population of UL for vitamin E. Therefore, the evidence that we identified here cannot be used for establishing a UL based on this endpoint. And then prostate cancer, we observed an increased risk of prostate cancer in the SELECT study, and this is really what the reason of these, the results of this study is why we prioritize this outcome in this assessment. We identified 3 other RCTs, however, that did not support this finding. This was also not supported by data from observation and animal data. And given the heterogeneity of the studies, it is unknown whether the effect observed in the SELECT study may be related to the form or to the dose of alpha tocopherol used, the baseline characteristics, or other unknown factors in this trial. The panel therefore concluded that the overall available evidence is insufficient to conclude on a relationship between alpha tocopherol intake and prostate cancer risk. So given the conclusion I just presented, the priority adverse health effects, and in line with the SCF conclusions, the panel considered that the effect on blood clotting and the increased risk of bleeding is the critical effect to establish a UL for alpha tocopherol for the general population. The selection of this critical effect is due to the well-established relationship between high doses of alpha tocopherol and impaired blood coagulation. No relevant new evidence being retrieved regarding the risk of bleeding events, and despite the progress in mechanistic understanding by which alpha tocopherol may affect blood coagulation, the panel found no basis to change the UL previously established by the SCF. So considering the totality of the evidence and related uncertainties, the panel retained the UL previously established of 300 micrograms per day for adults, which now applies only to steroid-isomeric forms of alpha tocopherol. And the UL also applies to women during pregnancy and lactation. There's no evidence that was found regarding specific susceptibilities or specific adverse effects in this population. This is also the case for children and adolescents, to which the UL is also extrapolated. And then we also derived this time a UL for infants. This was also based on allometric scaling. So the UL was extrapolated from the adult population. So that is it from my end on fat-soluble vitamins. I will now pass you on to Nena for the highlights on vitamin B6 and folate. Thank you.
Thank you so much. I hope you can see and hear me okay. So a warm welcome from my side as well. My name is Nena Karavasiloglu, and I will be sharing with you the highlights from EFSA's latest opinions on the B vitamins, so vitamin B6 and folate. As shown for the previous presentation on liposoluble vitamins, a number of outcomes were identified and explored during the hazard identification step for their potential relationship with vitamin B6 intake, either through systematic or narrative reviews of the literature. Looking at the evidence, the NDA panel considered that the available evidence does not suggest a positive relationship between vitamin B6 intake and congenital anomalies or growth restrictions in utero in humans across a range of intakes investigated in the included studies. Additionally, evidence from trials and observational studies did not suggest an inverse relationship between vitamin B6 intakes and birth weight and birth length in humans. Animal studies did not suggest a relationship between high vitamin B6 intake and developmental toxicity. It was noted, though, that there is some evidence that vitamin B6 supplementation at a dose of 35 to 40 milligrams per day is associated with an increased risk of hip fracture. However, the evidence available to date was deemed insufficient to conclude on the causality of the relationship, and a reference point on this observation alone could not be used. There was also an indication that vitamin B6 consumed at doses of 600 milligrams per day may suppress lactation. However, this level was well beyond the reference point that was used by the Scientific Committee on Food to derive the UL. Evidence for a relationship of high vitamin B6 intakes with other outcomes like photosensitization and dermatological lesions, impaired memorization, and testicular toxicity was insufficient. And as such, these outcomes could not be used to inform the UL for vitamin B6. On the other hand, there was experimental animal data showing that vitamin B6 causes peripheral neuropathy in a dose-related manner, and a similar relationship has been shown in humans as well. Now, I would like to spend some time comparing the current approach and the previous approach, as we received a number of questions on this during the pre-submission phase. So both in the SCF assessment in 2000 and then the NDA panel assessment in 2023, the peripheral neuropathy was identified and selected as the critical endpoint on which to base the derivation of the UL. And in both cases, the same case control study in women by Dalton and Dalton, published in 1987, was identified as the most crucial piece of evidence. In 2000, the SCF derived a reference point of 100 milligrams per day based on the Dalton and Dalton study, considering the average vitamin B6 intake in the study. And then they used this value to derive the UL for all age and life stage groups. On the other hand, the NDA panel in the current reassessment concluded that there is evidence that peripheral neuropathy may occur at supplemental vitamin B6 intakes of 50 milligrams per day. And this was additionally supported by case reports and vigilance data from the member states. Furthermore, a subchronic study in beetle dogs showed the supplemental vitamin B6 intakes of 50 milligram per kilogram body weight per day for around 100 days led to limited damage in the dorsal sensory nerve roots without the occurrence of neurological disease symptoms and provided the basis for a low IL in the current assessment. So how was the UL derived in the current assessment? There were two different lines of evidence. On the right-hand side, we have the human data, so the study by Dalton and Dalton conducted in women, where a reference point of 50 milligram per day was identified, to which an uncertainty factor of 4 was applied, and this led to a value of 12 milligram per day. On the left side, we have the subchronic study in beagle dogs, through which a low IL at 50 milligram per kilogram body weight per day was identified. Then an uncertainty factor of 300 was applied to account for interspecies variability in toxicokinetics and toxicodynamics, intrahuman variability in toxicokinetics and toxicodynamics, to extrapolate from the subchronic to chronic exposure, and to account for the absence of a NOAL and the use of a low IL instead. This, and when considering the standard body weight of 70 kilograms, led to a value of 11.7 milligrams per day. So these two pieces of evidence together led to the establishment of the adult UL at 12 milligram per day. And even though the study by Dalton and Dalton was exclusively conducted in women, we found no indication for a differential susceptibility in males, and as such, the UL applies for females, males, those pregnant and lactating. Then, when scaling the UL for the younger age groups, we found no indication of increased susceptibility for children or infants to vitamin B6 toxicity, and as such, allometric scaling was thought appropriate to scale the adult value for the younger individuals. As such, we arrived at two newly set values for infants, 4 to 6 and 7 to 11 months of age from the NDA panel. And as already anticipated by the use of a lower reference point and the derivation of a lower UL for adults, the UL was decreased for all age groups compared to the initial assessment by the SAF in 2000. In the opinion, the NDA panel also called for additional research regarding the potential differences in toxicity profile of the different vitamins of vitamin B6, as well as the need for further investigation of mechanisms of vitamin B6 toxicity and the identification of genetic traits that might influence individual susceptibility. Finally, further research is required to investigate the impact of other factors like age, sex, and epigenetics on vitamin B6 neurotoxicity, and the panel also called for further investigations or analysis of existing data to clarify the role of high vitamin B6 intake on bone health. And now moving on to folate. Here again, a number of endpoints were considered, and the NDA panel felt that the available body of evidence was insufficient to conclude on a positive causal relationship between high dietary intake of folate and risk of colorectal and prostate cancers. It was also noted that the evidence for a positive relationship between high folate or folic acid intake or folate status and risk of cancer in sites other than the colorectum and prostate was scarce. Findings on the association between folate intake and risk of insulin resistance or a potential effect of folate intake on the immune system function were limited. And as such, these endpoints could not be used to establish a UL for folate. Evidence for a positive relationship between maternal folic acid intake and folate status either pre or during pregnancy and the risk of allergies or the risk of autism spectrum disorders was scarce. evidence on the relationship between folate intake and risk of anemia was considered limited and inconsistent. And as such, none of these outcomes could be used to inform the setting of a UL for folate. On the other hand, the panel considered that the available body of evidence was insufficient to conclude on a positive and causal relationship between high dietary intake on folate and impaired cognitive function in individuals with low cobalamin status. However, the dietary intake of folic acid and a transient correction of megaloblastic anemia in cobalamin deficient individuals, which then could lead to the masking of cobalamin deficiency, has been well established. And as such, the SCF used this as the critical endpoint to derive a UL back in 2000. And they selected a UL of 1,000 microgram folic acid for adults. In line with the SCF, the NDA panel considered that the risk of progression of cobalamin-dependent neurological symptoms in cobalamin-deficient patients should be considered as the most serious adverse effect of high folic acid intake and be used as a critical effect to establish a UL. However, no new evidence has been published that could improve the characterization of a dose-response relationship between the intake of folic acid and the resolution of megaloblastic anemia in cobalamin-deficient individuals, and as such, the NDA panel retained the ULs set back in 2000. For all age groups, including pregnant and lactating individuals and younger individuals. However, at the time, the SCF had not set a UL for infants, and during our review of the literature, we were not able to identify data for infants. As such, we considered that there is no indication of increased susceptibility of infants to folate toxicity, and that folate concentrations in mature breast milk are in the range of 45 to 19 microgram per liter, approximately averaging 80 microgram per liter. And as such, we felt allometric scaling was the appropriate approach to scale the adult UL for the infant age group. And as such, the NDA panel newly set the UL values for infants at 4 to 6 and 7 to 11 months old and retained the values for the remaining age and lifestyle population groups. Before I conclude my presentation, I would also like to share some important considerations by the NDA panel and some topics for further research. The NDA panel considered that no statement can be made about the safety of 5-methyl tetrahydrofolate glucosamine salts and L5-methyl tetrahydrofolic acid calcium salts above the UL for folic acid. As such, the UL applies to the combined intake of folic acid and 5-methyl tetrahydrofolate salts under their authorized conditions of use. In terms of further research, the NDA panel felt that more investigation is needed into the relationship between high folate intake and risk of cancer, including colorectal and prostate cancer, as well as the risk of serrated adenomas and polyps. Further research is also required to clarify the impact of high doses of folic acid and 5-methyl tetrahydrofolate on brain structures and functions. Research is also needed to investigate whether the epigenetic changes found in interventions with high doses of folic acid in some populations are causally related to alterations in any phenotypic characteristics. And with that, I would like to thank you very much for listening to my presentation. It's now time for a short coffee tea break, and the following session on essential minerals will start again at 3:55.
Welcome back, everybody. I think it's time to resume, and I hope you had some minutes to stretch and to grab a cup of coffee or a cup of tea. I'm now inviting Leonard Matijevich to share with us highlights from the latest opinions on 3 essential minerals. Leonard?
Thank you, Androniki, and good afternoon to everybody. Indeed, in this part of the webinar, I'm going to present our upper level opinions related to essential minerals, selenium, iron, and manganese. Starting with selenium. For selenium, we have well-documented and established adverse effects associated with the exposure to high levels of selenium, a condition called selenosis, and it is characterized with clinical effects such as neurotoxicity, and it's also manifested as issues affecting hair, teeth, nails, and skin. The SEF and other authoritative bodies use selenosis to set the upper levels. Or to be more specific, the SEF based their assessment on the evidence from observational studies on endemic selenium poisoning due to high selenium concentrations in soil in some areas in China and the United States. So this was also a starting point for us, but obviously it was important to evaluate the new data over the last 20 years. And eventually we identified as being the most relevant 5 RCTs and 3 observational studies with new evidence on selenosis. Here, the main focus was on so-called SELECT trial because this was the largest RCT ever conducted with selenium supplementation. It involved around 8,700 individuals per study arm. All subjects were men above 50 years of age and were recruited from the general population in the United States. And the evidence would suggest that the effects from observed the effects observed at intakes below the previously identified NOAEL of 850 micrograms per day indicated some concern and also the need for a revision of upper levels. Besides those adverse effects characteristic to selenosis, we also reviewed other possible effects listed here in this slide, such as hypertension, Alzheimer's, all-cause mortality, and so on. And either we could not find a positive relationship or there was an insufficient evidence based on the available body of evidence to draw conclusions about the causal relationship. There was also no indication for a specific risk for pregnant and lactating women living in selenium-rich areas. However, we found the evidence from RCTs for a positive and causal relationship between the intake of selenium and development of risk of type 2 diabetes. But the expert certainty in the evidence from RCTs was at moderate level. Evidence from 10 observational studies, which we also consider, was unfortunately not supportive enough to increase this level of certainty. Now, when it came to hazard characterization and derivation of the upper levels, we selected alopecia as critical endpoint, being an early sign of selenium toxicity, and a daily dose of selenium increasing the risk for alopecia was identified to be 330 micrograms. This value was coming from previously mentioned SELECT trial. So this was our reference point. Then when we applied an uncertainty factor of 1.3 based on the expert judgment that alopecia is an early sign of selenium toxicity and as such a mild and likely to be reversible. And after we applied the uncertainty factor, we finally got the upper level rounded to 255 micrograms per day for adults, including pregnant and lactating women. Since we concluded that there was no available data to indicate that infants, children, and adolescents would be more susceptible to selenium toxicity, we used allometric scaling to extrapolate from the upper levels for adults to these subgroups of population, because this is the preferred method to adjust for metabolic differences between age groups. Here we can see those upper level values per subgroup of population, and some were decreased and some were slightly increased in comparison to previous upper levels established by the SEF more than 20 years ago. This is simply due to mathematical calculations because the SEF applied another approach to scale down using isometric scaling, which led to more conservative values. To wrap up this short part on selenium and upper levels, also to mention that the data was insufficient for us to characterize potential differences in the toxicity profile of different dietary forms of selenium, for example, organic versus inorganic selenium, although there are no differences in ADME profiles between them. So this was one of the topics we recommended for further research. Other topics are related to having better biomarkers of exposure and effect, further investigation in regards to selenium and type 2 diabetes, and finally, consumption data of food sources of selenium can also be improved. Okay, moving on to iron. Here in our previous work, this time the work of the NDA panel dated to 2004, we could not establish the upper level due to insufficient data. The evidence did exist from case reports about adverse gastrointestinal effects due to acute ingestion of non-heme iron preparations at around 50 to 60 milligrams per day, but this data about the acute intake was not considered as appropriate to establish an upper level, which, as we know, should be based on chronic intakes. Also, back then, an upper level could not be established based on systemic iron overload, indicator being here serum ferritin concentrations. We do know that iron can accumulate in organs, especially the liver, and lead to systemic iron overload. And this can happen even in healthy individuals at very high levels of intake. But it was simply not possible to develop a dose response curves between the intake, homeostatic adaptations, body burden, and adverse effects. So in our current work, we identified 58 RCTs in total with, of course, different characteristics regarding the study population, iron forms which were used, the doses and duration. And what we conclude initially from this data is that the threshold below which gastrointestinal effects are less likely to occur is between 20 and 50 milligrams per day of supplemental iron intake. Besides these well-established effects regarding systemic iron overload and gastrointestinal issues, we also checked other possible adverse effects like negative impact on zinc absorption, adverse effects in infants, young children and pregnant women, and type 2 diabetes. But for these outcomes, either there was no evidence that iron supplementation could lead to adverse effects, or the evidence was simply insufficient to draw the conclusions. Similar case like for selenium, except for impaired growth of infants and toddlers, which manifested as a lower weight gains. In this case, the body of evidence from 5 RCTs was sufficient to establish a positive causal relationship, but the level of expert certainty was considered as low. And because of that, this endpoint could also not be used to establish the upper level. So what does this all mean regarding hazard characterization and derivation of upper levels for iron? I mean, we know that upon iron dietary intake, there are no specific ways to actively excrete the excess iron through urine or bile, for example, but instead, body burden is regulated via absorption from food sources, up and down regulation. We do know also that systemic iron overload, especially leading to iron accumulation in the liver, is an adverse effect, eventually leading to iron toxicity, hepatotoxicity, for example. And this is well documented in people with, for example, hereditary hemochromatosis or in patients receiving frequent blood transfusions. They are then at higher risk of adverse effects. So these findings we used for hazard identification, as mentioned previously. But alone, this data we could not use for setting an upper level based on the liver toxicity in general population. Regarding gastrointestinal effects, again, we do have studies suggesting that taking more than 50 milligrams per day of certain iron supplements like ferrous sulfate, fumarate, or bisglycinate can cause gastrointestinal issues, which is likely because unabsorbed iron remains in the gut and causes mucosal damage. However, there's no clear dose-response relationship, meaning it's uncertain how much iron is needed to trigger symptoms consistently. And with respect to iron-replete infants, what we found is that the data suggests infants who receive supplemental iron doses at 1 to 3 milligrams per kilogram of body weight per day, they may experience lower weight gains in comparison to unsupplemented iron-replete infants. However, as mentioned in the previous slide, the evidence is not strong enough to conclusively link high iron intake to impaired growth in these children. So this effect was also not used as a basis to set an upper level. So overall, the data was simply inadequate to characterize a dose-response relationship and to identify the solid reference point or LOL from available studies. And therefore, no upper level for iron could be established. Then, what about some surrogate endpoints which would allow us to establish the safe levels of intake as an alternative to upper levels? For this reason, we consider the evidence for the presence of black stools because it reflects the presence of large amounts of unabsorbed iron in the gut, and this was the only reliable endpoint with sufficient data to characterize a dose response, although it is not an adverse event per se. So we had the data from 3 RCTs with iron supplementation between 20 to 80 milligrams per day, which indicated that the presence of black stools does not occur at levels below 40 milligrams per day. And then this value of 40 was considered as a safe level of intake of total intake of iron from diet and supplements for general population, including pregnant and lactating women. Regarding the safe levels of intake for other subgroups of population, we use allometric scaling for children from 1 year of age onwards, but we had specific considerations for infants below 1 year of age, mainly due to higher dietary iron requirements, especially in the second half of the first year of life. So for them, there was a slightly difference in extrapolation because allometric scaling was not used based on the safe level for adults, so from 40 milligrams per day, but from the highest supplemental intake in adults, which was considered as safe, and that was 25 milligrams per day. That also means that such safe levels for infants are not established for all dietary sources, but only for supplemental iron intake, which means coming from the fortified foods and food supplements, and does not consider the iron intake from infant and follow-on formula. Here we can see the safe levels of intake for all subgroups of population, and all of them are newly established in comparison to previous work. As explained earlier this afternoon, the application of safe levels of intake for risk assessment and risk management is more limited than an upper level because the proportion of people at risk of adverse effects in a population cannot be estimated. And this is because of the intake levels at which the risk of adverse effects starts to increase is not defined. Also, it is important to mention that in a situation when iron deficiency anemia needs to be treated, then similar or higher levels than the safe levels of intake are used. So the safe levels of intake proposed by the panel do not apply to individuals who receive iron under medical supervision. And lastly, we have manganese as a third essential mineral under our recent mandate. Here, the main focus was on manganese-caused neurotoxicity. As in the case of selenium, here we have a well-documented condition called manganism. It's a neurological disorder similar to Parkinson's disease, including neuropsychological abnormalities such as impaired motor skills, tremors, facial muscle spasms, and difficulty walking. All of these have been primarily observed in workers due to occupational exposure to manganese via inhalation and in some case reports with oral intakes of high amounts of manganese. The proposed mode of action, although still not very well understood, is that the accumulation or increased manganese levels in brain, especially in basal ganglia region, lead to oxidative damage since these regions are especially sensitive to oxidative injury. We did investigate also other potential endpoints, mainly related to developmental toxicity, infant mortality, preterm births or birth defects, and also metabolic syndrome. But the evidence was simply very limited and we decided to focus on neurotoxicity as critical endpoint. Now, one of the first challenges we encountered in this risk assessment is that there are no reliable biomarkers of exposure to manganese. Most promising biomarker would be the brain levels, but they are investigated with the MRI scan, so in general the data is not robust enough. So our assessment included systematic review of both human and animal data, especially human observational and interventional studies investigating cognitive impairments like lower IQ or performance in school when regards to children, impairments in motor function, impairments related to behavior like attention deficit hyperactivity disorder, ADHD, impairments in neurodevelopmental milestones in young children related to speech and language disorders, hearing loss, and so on. But all this data was available mainly from observational studies with few case reports and only one RCT, but in adults. Another big limitation from these studies was that there was insufficient characterization of total manganese dietary exposure because studies mainly focused on providing the data on manganese concentrations in drinking water. And we know this is a relatively small contributor to the overall dietary intake of manganese, and alone often indicates quite low intake levels, being 2 to 3 times lower than the adequate intake for manganese, being an essential mineral. Furthermore, there were concerns regarding incomplete adjustments for confounders, like presence of other minerals or contaminants and so on, and uncertainties regarding temporality of the relationship, being that the evidence was mostly coming from ecological or cross-sectional study designs. So we really needed to switch our focus from human data to data coming from animal studies, but again, having the emphasis on studies investigating neurotoxicity. Here again, endpoints like changes in motor and sensory functions were considered, changes in cognitive performance, anxiety, and so on. The overall body of evidence from animal studies confirmed that manganese is neurotoxicant. We did not have particular evidence to conclude that pups or young animals would be more susceptible to manganese neurotoxicity, but overall, there were again a lot of uncertainties which eventually did not allow us to establish a reference point. For example, one curiosity was that in many studies we found already in the control group, or to say in the background diet given to all animals, the manganese levels were quite substantial, and what was added in the intervention or in the dose groups was actually a smaller contributor to the overall manganese intake. And in general, animal studies were mainly mechanistic studies, not allowing us to see any dose-response relationship. So we did confirm that available both human and animal data support neurotoxicity as a critical effect, but no reference point, low oil or no oil, could be established, and no characterization of a dose-response relationship could be plotted. Then, as in case of iron, we needed to think about the alternative to upper levels, so we focused on establishing the safe levels of intake. And in case of manganese, we opted to establish safe levels of intake based on the observed intake data of high consumers of manganese in European population, because there is no evidence that such intake levels would cause adverse effect. So basically, the safe levels were established on the basis of observed dietary intakes of manganese from regular diet, natural sources only. And here we took the intake data for high consumers, meaning at 95th percentile of intake, and we averaged 4 highest P95 estimation coming from dietary surveys among member states for all subgroups of population to take into account the metabolic differences between the surveys. So this was done for all subgroups of population except for infants. For infants, we did not have sufficient data to determine when manganese homeostatic processes become fully mature during infancy. So we took a more conservative approach by calculating the average of all available P95 values for infants. Here again, we can see all those safe levels of intake for manganese, which are applicable to total manganese intakes, meaning from all dietary sources, including fortified food and food supplements. And all were newly established because the previous work of the SCF did not establish health-based guidance values. Although the SCF concluded that manganese intakes beyond the intakes from normal diet could represent the risk. Here again, due to conceptual limitations of the safe level of intake, we cannot fully characterize the risk, or to say more precisely, we cannot determine subgroups of population who may be potentially at higher risk of manganese toxicity due to higher manganese intakes coming from specific diets, like, for example, vegetarians or tea drinkers, or some individuals with specific genetic mutation influencing the metabolism of manganese. And our recommendations for further research were mainly focused towards previously mentioned limitations in data, such as lack of reliable biomarkers of exposure and effect, and overall need for better human and animal studies. And finally, we do have one pre-submitted question here in regards to manganese. I will just read it and then provide an answer. So it says, the driver for manganese upper level seems to be based on safe intake and therefore deviates from approaches such as that of the WHO looking at adverse data. The adopted safe level now does not align with more recent opinions from the WHO or, for instance, local ones from ANSES. How should this safe level be used in light of the other more stringent levels being also out there? Well, the reply is actually quite simple. Regarding those two mentioned risk assessment by WHO and ANSES, if we identify them correctly, but we are really not familiar with other work from these bodies, their goal was to establish some guidance levels for manganese, but in drinking water only. So our approaches are simply not directly comparable because our safe levels apply to all dietary sources of manganese. And with this, I would conclude my part on essential minerals, and now I would like to give the floor to my colleague, Lucia. Thank you very much.
Lucia, you're muted.
Okay, sorry. So good afternoon from my side. My talk will be about estimating the intakes of vitamins and minerals and identifying the at-risk populations in the EU. So to set the scene for my presentation, I would first like to show this very first slide that you have seen already at the beginning of the webinar, just to explain that the part that I will cover in my talk represents two of the pillars of risk assessment, where intake assessment is considered the evaluation of the distribution of usual daily nutrient intakes in the general population. And the risk characterization is the determination of the risk of adverse effects in EU population, and if applicable, also the identification of at-risk population, meaning not covered by the upper levels. So how did EFSA go about estimating nutrient intakes from different dietary sources? Well, we started from the indications included in the guidance for establishing upper levels that you have heard about at the beginning of the presentation, and that says that a comprehensive characterization of the risks associated with the dietary intake of a nutrient requires a complete intake assessment from all dietary sources. What does it mean? It means that we need estimates of the nutrient intake from its natural sources in the diet, including water. We need estimates from the nutrient intake from its addition to foods, meaning in fortified foods, and also estimates of the nutrient intake from its use in food supplements. So while our databases, our composition and consumption database that I'm going to talk to you about in later slides, are very well equipped to provide estimates which are reliable for the consumption of nutrients from foods which are naturally rich in these nutrients, we had to conclude that these databases are not do not provide good enough information to also estimate the intakes coming from other sources like fortified foods and food supplements. And this is the basis for our approach to intake assessments in the context of this mandate. So what did we do? We estimated harmonized intakes from the background diet, meaning, as I said, from those foods which are naturally rich in this nutrient, and we excluded from these intakes the contribution from food supplements. Now, as we have received a specific question from one of the registered attendees on that, I would really like to specify that indeed we were not able to estimate the intakes from these other food sources, and that specifically for fortified foods, for some nutrients, namely for vitamin A, vitamin D in other population group than infants, for folate and also for manganese, we were able to disentangle the contribution from fortified foods from the rest, but for others this was not possible. However, for the other nutrients that you see here listed in the bottom of this box, we could still conclude that the contribution from supplements was minimal. But then how to inform better our risk characterizations, and also how to inform better our opinions and provide more information to the public on what's the situation with concerns with regards to the intake from other sources than the natural sources. We decided to do a step forward and to we collected data estimates from specifically from fortified foods and food supplements, but also from the background diet, from national dietary consumption surveys and total diet studies, meaning that we contacted around 64 national organizations in 37 European countries, asking them to provide us with their national estimates. And we also extracted label data from the Mintel Global New Product Database regarding the content in fortified food and food supplements available in the EU market. And I'm going to explain to you in a moment how we use this data. But first of all, let me explain to you what are the sources of data that we use when estimating the intakes, not only for nutrients, but for other intake assessments. So on the consumption side, we have the comprehensive European food consumption database. That is the most complete and detailed collection of food consumption data currently available in the European Union. It compiles existing national data on food consumption at individual level. And at the time of the intake assessment that I'm discussing with you today, there were 49 surveys from 23 member states. Since 2011, EFSA has funded 21 dietary surveys on children and or adults from 21 countries, and under the EU menu project and methodology. The data collected have been collected through different methodology, 24-hour records or dietary records, with a number of days ranging from 2 to 7 per subject. Data are collected in random samples at national level in different age classes, starting from infants to elderly, and in special population groups such as pregnant women and vegetarians. Specifically for nutrients, EFSA used the EFSA food composition database that contains food content of vitamins and minerals coded in EFSA's FoodX2 classification system. Data are provided by 14 national compilers covering approximately 1,750 foods and composite dishes. Data are derived in a different way, be it from scientific literature, or they are analytical data, or are borrowed from other countries, or from other foods which are considered to have analogous content, or they are calculated from recipes. On the left side of this slide, you see that the matching of the data from the food consumption database and the food composition database, both coded according to the FoodX2 classification system, is the basis of our intake estimation. And for the nutrients under investigation, we have estimated the intake from the background diet, as we said. We provide, in all our opinion, a complete data set of representing the estimates by sex, by country. We provide means, P95 intakes, for all the age and population groups that you see in this slide. And you can see also other information in these data sets that are attached to the opinion under supporting information, and they can be downloaded and accessed freely. You also have information like the percent contribution of different food groups to the total intake and more. But how do we present this wealth of data that we have and we make available also in our opinion? So here you see just an example. I take the example of the folate opinion, and just for the adults. You see here one illustration of the linear plots that we present in the opinion to summarize the estimates. You see in these slides these linear plots represent the P5, the P95, the median and the means for females and males per each country for which we have surveys included in our comprehensive consumption database. And it is a visual representation which is very helpful to see where we stand regarding the average and also the high consumers intakes. Of course, I direct you to check all the opinions that we have been discussing today to see the same representation of the intakes. But now, as I anticipated in my previous slides, we did not stop at this assessment of the background intake. We moved forward. We also collected data. And you see on the right side of this slide some representation of this data. You see these are all the surveys that we have, from which we have received data. Most of them are presenting intakes from the background diet and fortified foods. Also, in this case, was very difficult to find data which will be only from background intake or only from fortified foods. And two of these surveys presented data on the overall intake from all sources together, and only a few from food supplements, which provided estimates from the intake from food supplements only. Just a few comments on the data that we have provided. Of course, we had we noticed that the methods of estimation of the intake from fortified foods and food supplements are very diverse according to the surveys, and some of them are using only one method. Some of them are actually matching methods, like matching 24-hour records, for example, with food propensity questionnaires, which is a way to estimate more realistically the intake of foods like food supplements and fortified foods. The estimates of contribution for fortified foods and food supplements to total intakes in new population are scarce, and they are and their contribution is very much dependent on the country. Also, we could only have estimates of the total intake, so from all sources, in users only from a few surveys. Regarding the extraction of label data from Mintel, well, we use this product label database to extract data from the labels and from nutrition declarations specifically. So we could see by category of product in the EU market over the last 5 years, the content per serving for both supplements and fortified food as recommended by the manufacturers. Indeed, this is just a snapshot of the market. It does not represent necessarily the totality of the products available in the market. But it is indeed a qualitative information, and I'm going to show to you in the next slide how we made use of these data, although we could not integrate them in our intake assessments. So in these slides and in the following one, you see plotted with a circle, with a white circle and a red triangle, the median and the max dose per serving in food respectively, for all the nutrients that we've been discussing today. And they have been compared here with their dietary reference values. In blue, the population reference intakes and or the adequate intake, and in orange, the upper level, and in yellow, the safe level of intakes as applicable. So what can we say here? We can say that for the nutrient in these slides, indeed, the median dose per serving in food supplements remains below the population reference intake or the adequate intake, or goes a little bit beyond, like for vitamin E. For the case of the maximum doses, well, you see that for vitamin A and selenium, we are below the upper level, although we are above PRI and adequate intake. But for folate, it goes well beyond the upper level. And the situation is a bit different here in the second slide, where you see that the maximum doses are going beyond upper levels and safe level of intakes, basically as on for all nutrients. Here we just represent the plots for adult males, but you can see at the end of this presentation, which will be made available, also the same plots for adult females. So what can we say now after having gone through all these data that we have collected? So now we have upper levels of safe level of intake. We have estimated the intakes. How do we characterize the risk of exceeding this upper level? So I can give you a glance of all the findings that we have in our opinion, that our conclusion. Overall, intake estimates in high consumers from all sources, including fortified foods and food supplements, which have been reported in national surveys, were below the upper levels or the safe level of intakes, with a few exceptions in a few population groups and few surveys. And there are some specific considerations that I would like to mention today to you, is that when we consider regular consumers of high-dose food supplements, and you have seen that in the market we have some high-dose supplements indeed, upper levels or safe level of intakes could be exceeded. Now, going specifically to some of the nutrients that you have heard about in previous presentations. So selenium, for selenium, upper levels could be exceeded in regular consumers of Brazil nuts, which are extremely rich in selenium. Beta carotene you have heard about in the presentation by my colleague, that smokers should avoid supplements containing beta carotene, and that supplemental beta carotene considering supplemental, including also fortification, yes, but the general population should be limited to the purpose of meeting vitamin A requirements. Lastly, for preformed vitamin A, ULs are unlikely to be exceeded if consumption of liver, offal, and products thereof is limited to once per month or less. My last slide is just for my concluding remarks. So I would say that indeed, compared to the past, we have we are able to provide more information on the intake from sources which are not specifically coming from the background diet, but are on top of the background diet, but we are not there yet. So we definitely need more harmonized data collection methods regarding consumption of fortified foods and food supplements. We need more complete food composition databases, and EFSA is very busy these days with different projects to address this limitation, and I would like to just mention two of them. One is an outsourcing regarding preparatory activities for the new phase of the EU menu surveys, for which we have launched today a call. And in fact, it is properly to try and enrich the next phase of surveys funded by EFSA with a central food propensity questionnaire properly to improve the assessment of the intake from fortified foods and food supplements. And there is also an ongoing project on the update of the food composition database, which means that in the future we are going to receive updated data on the content, on the nutrient content of foods from 16 national providers. But the idea is to have more regular updates also in the future by the member states. And this is with a view of improving the nutrient intake assessments and risk characterization at EFSA. So this is my last slide, and I would now like to give the floor to Androniki for the part on addressing the questions submitted by the registered attendees and her additional concluding remarks.
Thank you, Lucia, and thank you all for this comprehensive overview of a huge amount of work. In the last part of today's presentation, we are going to address some of your submitted questions, which have not been addressed so far during the presentations. And we shall begin with the first one. So for the questions that will follow, I will read the question as it was submitted, and I will try to provide the corresponding reply. So question number 1. In the context of the shifting to a more prominent plant-based diet, I would be happy to have some insights on the vitamins and minerals added to the so-called plant-based food products and the potential risk of deficiency or excess of such micronutrients. EFSA has not specifically and systematically reviewed the vitamin and nutrient composition of the so-called plant-based food products. I'm sure the requester will keep us right by saying that this is a rapidly changing market, a rapidly growing market, and to provide insights would require a dedicated project. However, we invite the requester to follow FAO's activities on this matter, and actually FAO is preparing a report to be published by the end of this year with a description of the composition of plant-based protein sources, which are expected to replace animal-based ones. Question number 2, how will the upper levels affect novel food applications? The consideration of the upper levels is an integral part in every novel food safety assessment. And the reason is simple. The panel needs to check whether the anticipated intake, in case the novel food is to be released in the market, whether this anticipated intake would result in an exceedance of the upper level of certain nutrients. This is why any update on the upper levels is immediately applied and followed in the novel food assessments. And again, if the requester would like to receive more information on this, we would refer them to the recent update of the novel food guidance, which was published in late September this year. In question number 3, the issue relates to the harmonization of mineral addition across Europe. For instance, in the case of iodine, the permitted quantities and even the compounds that can be used vary from country to country. Are there scientific reasons that justify this lack of harmonization? This question very much relates to my introductory remark on the difference between risk assessment and risk management. Indeed, the maximum permitted amounts of nutrients to be added to foods or to be used in food supplements is a task within the risk management process. And it is true that in setting those maximum amounts, several country-specific factors, together with other factors, need to be considered. Just to give you an example, issues like the nutritional status of the population or the background intakes are issues that have to be taken into account. And therefore, specific policies to address the nutrient deficiencies or insufficiencies in certain population are a competency of EU member states, and they are managed at national level. Question number 4 asks whether an upper limit leaves room for food fortification and or food supplements. When this happens, whether EFSA has a preference and why. Again, voluntary fortification or mandatory fortification and or supplementations are issues related to risk management, and this falls outside EFSA's remit. Next question asks about the reasons for which EFSA recommended ULs are different to those of the FDA. We interpret this question as asking why EFSA ULs are different to those set by the US National Academy of Science, Engineering and Medicine, because in a way this is the equivalent, if we could say that, to EFSA body in the US. The reply could be rather simple in one word: timing is the key issue. Scientific evidence is generated as we speak, and ULs should rely on robust, eligible, reliable evidence, and of course, recent evidence. So most of the difference are due to different time points, different review of the literature based on what was available at the time of the assessment. When discrepancies are observed, we strongly invite the readers, the interested bodies, to pay attention on the year of publication, on the critical effect chosen, and on the year of publication of the papers of the scientific evidence which are used to set the upper levels. However, we should admit that there are subtle differences in the methodologies applied by international bodies such as WHO and national agencies. And it is true that worldwide there are several efforts going on trying to harmonize these approaches, and EFSA is actively participating in them. Regarding the upper level of magnesium, that was set in 2001, and the NDA panel has not received a mandate to update the upper level of magnesium. The last question on this slide asks whether there is a security risk for nutrients for which there is no upper limit, such as vitamins, those listed C, several B vitamins, K, and among minerals, potassium, chromium, and silicon. Let us clarify before anything else that the lack of an upper level does not mean that there are no safety concerns. In most, if not all cases, the inability to set an upper level stems from the inadequate evidence. And actually, the new element in our recent approach in comparison to the past, as I mentioned also in my introductory remark and Agnes explicitly described, is the fact that the European Commission in the last mandate asked, if you are unable to set an upper level, we need your advice on the highest level of intake, for which, with reasonable confidence, there is no doubt, there is no possibility of an adverse effect. If the requester would like to receive more information on what was the status when these vitamins and minerals were visited, and actually the evidence was reviewed in 2003, they are kindly invited to follow the 2005 report, and you can use the QR code in the top right-hand corner of the slide to download this report. The next question asks whether could upper limit be different for specific populations such as vegans, athletes, and so on. EFSA's UL address the general population, and of course, vegans, athletes are part of the general population. And in the evidence we have reviewed so far, we didn't find any indication that the upper levels of the vitamins and minerals reviewed should be different for these population subgroups. However, as we mentioned in our guidance document, there may be cases where population subgroups should be excluded from the setting of the UL. And that could be, for instance, a case where some individuals are more susceptible or to a high intake, or on the contrary, are in need of higher intakes because of their genetic predisposition. That could also be a case. Question number 10 addresses another population subgroup, cancer patients, and the requester asks, for food products intended for adults with cancer, do you recommend fortifying with vitamins and minerals, or do we not know enough about the interactions with the disease? And goes some steps further, asking if yes, in which elements and at what level, and if there are any differences from one cancer to another. Cancer patients are monitored by health professionals, and any dietary advice should rely on recommendations provided by the competent medical bodies. And these population subgroups are outside EFSA's remit. Is it possible to give a very brief overview of the maximum levels of vitamins and minerals in each country of the European Union, or present a table showing the variations between the regulations and the threshold values identified by EFSA? Another question that addresses country-specific issues, which, as I have already said, are part of the risk management process. Therefore, EFSA does not keep track of the different values and the different regulations that are set on a country basis. The next question addresses a specific product, propolis, and asks whether it must be standardized to make it possible for beekeepers to put it on the market, because most of the people are using it without knowing what are they using. One of the analysis that has to be done before propolis make it on the market is mineral composition. What do you think of that? Again, this is a question that addresses risk management issues, and the requester is advised to contact DG Santé to address such issues. Question number 3 to us was not particularly clear. It was structured as such. Any update of the approved form of isomers for vitamin and mineral. We are not sure on what is the content of the question, and we strongly advise the requester to reformulate, to clarify, and submit it again to ask EFSA. Question number 14, is there a study research regarding effectiveness of taking vitamins via natural foods or versus vitamin pills? Also, is there a difference due to timing, like during morning, before or after a meal, of consuming food with certain vitamins or taking pills? All the aspects that are mentioned in this question, as well as several others that lie behind, are addressed in our opinions. And they are considered in selecting critical effects, in selecting the evidence, in synthesizing the evidence and reaching conclusions. We would therefore refer the requester to the opinions for upper levels, as well as to all the DRV opinions of the EFSA NDA panel, where issues such as bioavailability, which is obviously behind this question, are explicitly described and presented. Are there any plans for an upper levels review for other micronutrients? As we mentioned in our introductory slides, any review should come after the European Commission's request, after a mandate is provided to EFSA NDA panel, and as of today, there is no new mandate to update the upper level of other micronutrients. Now, if I recall correctly, there were also a number of questions regarding the maximum amounts in foods and food supplements, and they were asking information about the timeline, technical questions, implementations, plans for follow-up assessment, and standard analytical tolerances. As I repeatedly mentioned, and I apologize for repeating myself, maximum permitted amounts are part of the risk management process, and for this are outside EFSA's remit. Closing today's presentation and closing the last 4 years, as I said, of a huge and challenging work, I would like to share with you some points for consolidation. To my reading, to my understanding, an important achievement of this work was the engagement. As Agnes mentioned earlier, the work that was presented today was the outcome of several groups of experts from Nordic countries working on the systematic review of the evidence. It is also the outcome of a panel of experts from Europe and abroad who were members of EFSA's UL working group and synthesized the evidence and provided the preliminary conclusions. These conclusions were then discussed in the NDA panel of experts, and the NDA panel combines not only the expertise, the knowledge of the field, but also the experience of users of the values. And last but not least, all the opinions before being finalized, they were released for public consultation, Comments were received from national and international agencies, other stakeholders, individuals on their own capacity, and all comments were addressed before the opinions were finalized. Another important aspect in this work was a comprehensive review, which do not only relied on toxicological aspects, but epidemiology in terms of chronic conditions was also part of our discussion. And this is a new element in setting upper levels for the European populations. Transparency was a horizontal priority in all our work, and I would particularly like to highlight the transparency in describing our inherent uncertainties, which was important not only to understand the strengths and the weaknesses of our data, but also to identify ways forward, to come with recommendations for the future, which will shape new assessments of upper levels for the European populations. And lastly, next to the ULs, the Commission asked for advice in any case, even if the evidence was not robust enough. And a new term was introduced, that is the safe level of intake, which, as Agnes rightfully highlighted, is a term that needs to be interpreted with caution. And of course, I could not go without mentioning the values themselves, which are all integrated into a new version of the DRV Finder. And I think that the next slides, firstly, provide the DOIs of the different opinions. You will have access to the slides, so you can use the DOIs to access the opinions. And the next slide is the very nice new interface of the DRV Finder, EFSA's DRV Finder, which allows you access to all the dietary reference values, including average requirement, adequate intakes, upper levels. And this can be presented by target population or by specific nutrients. They are available. The Finder is available in different languages of the European Union, as you can see in the right-hand corner. And it has recently been, as I said, the interface has been updated to be more user-friendly. And with this, I think we are reaching the end of today's webinar. Thank you very much for attending our webinar. We started our discussion by the introduction of the head of the Nutrition and Food Innovation Unit, Ana Luisa Alfonso, welcomed you when you arrived. And I'm here to say to all of you, thank you very much for your time. Thank you for your interest. And there are several other slides that relate to any ways through which you can stay connected with EFSA's work. And I think this is the last one before the complementary slides about females that Lucia mentioned before. Once again, thank you very much. Thanks to the presenters and thanks to the attendees. Rest well, enjoy the rest of the afternoon.